learning session. We're really excited for this program today, for our incredible group of speakers, and for all you participants. As you'll see when we start to poll you and identify who you are, this is a really great diverse group of attendees. So thank you all for getting up early this Sunday morning and joining us for this important program. The theme of our day today is comprehensive medication management in partnership with health plans. And for those of you that have been with us in previous collaboratives, there's an evolution of the title, right? It evolves as things progress. And I think you'll be really excited about the work that's been done since the last learning session, despite some of these incredible challenges that we face today in our healthcare system. I'd like to start this morning off by introducing our Dean, Dean Vassilios Papadopoulos. He would like to share a few words with you all, with all the attendees. So Dean Papadopoulos.
Thank you, Steve, and thank you for this nice pre-COVID peak. So good morning, thank you for being here on a Sunday morning. Welcome to the California Right Meds Collaborative Fall 2020 Learning Session. So as Steve mentioned, the purpose of today's meeting is to really continue to advance the framework for delivering optimal results from medication therapy through comprehensive medication management sustained by value-based payments for the most vulnerable high-risk patients. It takes commitment, it takes time, resources, and effort to organize meetings like that, and even more now in the COVID-19 Zoom era than previously. And I would like to recognize a few people and institutions who made this happen. First, I would like to thank the partnering health plans, LA Care and Inland Empire Health Plan and their teams, the pilot pharmacies, the students from schools, health plans, and pharmacies, and particularly USC, CRMC fellows, interns, and volunteers, and Dr. Steve Chen, the fearless leader of this effort, and the CRC team, Jessica Abraham, Connie Kang, Maria Romero, Diane Yun, and Tu Tian Yuan. Many thanks to today's speakers who will share their expertise and ideas for this effort. And also I would like to recognize some special guests and organizations who are here. Ms. Susan Bonilla, the CEO from CPHA, Pauline Chan from the Department of Health Services, Ann Sodergen, Executive Officer of the California State Board of Pharmacy, Dr. Fong, USC alum and Director of Pharmacy at Alice Pharmacies, Dr. Kim, CEO of Arin, Dr. Lee from Mercy Pharmacy, Dr. Kim, owner of Plaza Pharmacy, Dr. Tai, CEO of 986 Degrees Corporation and immediate past president of CPHA, Dr. Cho from OptimaRx, Dr. Vils from CVS Pharmacy and the Board of Pharmacy member, Drs. Becker Ellison and Vivi Vo from Blue Shield, California, Dr. Vogler from Genoa Healthcare, HealthNet, the Riverside University Health System, Sutter Health, LA County Department of Health Services and Public Health, and at last but not least, the many pharmacy schools that participate in this effort, UCSF, Loma Linda, Western, KGI, American, UCI, and Marshall B. Ketchum. So I leave you now in Steve's hands for the remaining of, for the entire meeting. And thank you again, everybody who's here to participate in this effort. Thank you, welcome.
Thank you, Dean Papadopoulos. Very much appreciate you joining us. So before we even get started, I think all of you are wondering, well, who are all these people that the Dean just named? So we're gonna do a quick polling and check in on who you are and some of what you're doing in this space. So can I get the poll questions up, please, that we have for our group? Here we go. Hopefully you're seeing it now. You have to scroll down. There's more than one question.
So I'll give about another 30 seconds for the poll, and I'll end the polling to see the results.
It's a pretty good dominance of community pharmacists so far, but plenty from health plans and health systems. So a nice blend. A few students and residents. Have to figure out who those other people are. Okay. Okay, and it looks like a little more than half of you have been to our learning session before, so that's great, but another half have not. So we're gonna try to make sure that we have information, instructions, and programming for everybody. All right, I think that's good. We can probably move on to the next question. Can we see the results?
Sure.
Okay. Now, my results are different, but my screen is different. So as you can see, mostly community pharmacy. Again, pretty good representation from health systems and clinics and health plans. We have a few residents and students joining us. Welcome, the future of pharmacy. And 60% of you have been to our meetings before. So welcome back. And for those other 40%, I think you'll like what you hear. Okay, next question, please. Okay, you should be seeing it now. In the past year, what has been your status of engagement in CMM? And then a question about how many patients you've provided CMM in the past year. And the last question, what prevents you from offering CMM to more patients? Let's try to get this done pretty quickly if we can. I know we don't want to spend too much time on polling. All right. Okay, we can probably show results pretty soon. It looks like most of you are increasing or expanding your CMF efforts. That's really exciting, great to hear. But an even number either not engaged or have maintained and stayed about the same. And unfortunately, a few of you had to cut back this year. And I think this is a very challenging year when perhaps understandable in some regards. Next question, the past year, how many patients have you provided CMM to? Most are, it sounds like you're just getting started, somewhere in the neighborhood of 0 to 10. We have a couple of stellar folks that, actually I should say greater than 500. So I'm assuming the 4 of you have more than 500 patients, but the majority are in the below 50 range. So that tells me that this is a great program for you to participate in, because there are some amazing speakers today that have done a lot of CMM in their career that will share some great insights. And the last question, what prevents you from offering CMM to more patients? It's a lack of referral, which is something we will talk about today, lack of payment, lack of HIE, EHR access. And then the last one is unclear on the value of CMM. And so hopefully we will touch on all of these things today. And I think all of you that have expressed in different areas of limitations, I think there's something for all of you. So thank you so much for participating in the poll. Appreciate it. All right, as Dean Papadopoulos kicked off, this is our purpose today. It's to continue to advance the proven framework for delivering optimal results for medication therapy through CMM sustained by value-based payments for the most vulnerable high-risk patients. Sounds like a long sentence, but this is really what we're all about today. I need you to keep this in mind, because we will keep revisiting this theme and have some questions and deliverables for you at the end of the session. This is all grounded in the fact that we remain as a country, last place of all developed nations in healthcare quality, despite spending far more than anyone else per capita. And a big reason for that shortfall in healthcare quality has to do with medication use. $528.4 billion are of avoidable spending occur each year because we don't optimize use of medications. 3/4 of hospital admissions largely are medication related, represents at least a 4th leading cause of death in the US. These are not new stats to you all, but it's a reminder that we need much better focus on medication therapy optimization if we want the kinds of health outcomes that we deserve for the amount of money we spend in this country. So the mechanism for this is what we're talking about today, the California Right Meds Collaborative. The vision is to provide optimal medication therapy for high-risk patients in their communities, with the mission of creating this network of pharmacists in the community that provides sustainable, high-impact CMM that's aligned with payers, the health plans and health systems, population health priorities. These underlying words are really important in terms of the focus of what makes CalRight Meds different. The vision, in a very simple picture, is health plans that are part of this collaborative are going to stratify patients from high to low risk We'll be working together with the health plans to create these networks of community pharmacies that can deliver high impact CMM services. The high-risk patients are referred out to these pharmacists to receive comprehensive medication management. They're compensated in a value-based payment model that limits risk to the health plan and pushes accountability to the pharmacies to deliver outcomes. And we have various schools of pharmacies that are part of this, that are not just operating CalRight meds through their own pharmacies, but also working with other local pharmacies to improve their ability to deliver CMM. And I want to make it clear that these are the initial partners, Loma Linda and Western and USC. There are more than enough to fill in the other circles. We just haven't yet assigned them any pharmacies to work with. So what makes it work? I just want to recognize the people that make this work the way it does. And it starts with my USC team, some with us now and some not with us anymore. Amazing group of people, my right and left arm, could not get the work done without it. Really importantly, I hope you're hearing that this is a collaborative that's grounded with the payers, with the health plans, because at the end of the day, we can be really excited about the potential for pharmacists, but if the payers don't buy into it and don't support it and don't work with us, it just doesn't happen. And so I'm very, very grateful for LA Care and IHP for their willingness to partner to take a risk, to step out of the box and really carry a lot of this work. They've been phenomenal partners, so grateful. I have a number of people that I call the innovators, the people that find opportunities for us to expand and do more things. And here's a partial list of them, including Dr. Bill Harris, who I'm so fortunate to have his endowed chair. His support, his insights, his experience are so critical to our work. And then on the bottom, I put these folks on the bottom, not because they should be on the bottom, but because they're really the foundation of healthcare, in my opinion. These are many people that are speaking today that have been really the people that have mentored me and have led the nation, the state, and the county in innovating healthcare. So I'm really excited that you could hear from several of them in this session. So what have we been doing since the last time 60% of you met with us in fall of 2019? Well, a lot. This is a list of 10 things that we set out to do. And as you'll see later, we've done a lot of work in all of these areas. Not going to go into detail, but I will check those boxes for you when we get to this session later on the CRMC journey. So don't fall asleep and don't leave your computers. A big part of what we're doing is what we're doing today, which is heavy training for anyone that's part of the collaborative. So some of you are familiar with this. This is the Institute for Healthcare Improvements Breakthrough Series for Collaboratives. We've adopted it for the California Right Meds Collaborative. And I think this part on the left I've shared with you before. We have the mission, we have our leadership committees, we've had a kickoff session, we had our meeting last year at the Langham in Pasadena, and of course now we're in the fall 2020 learning session for the collaborative. Between each of these learning sessions, we have these action periods, and as I said before, to preview what's coming up, we will have a breakdown as to what happened in that last action period, and then after this meeting, we'll have another action period before our next learning session scheduled for April of 2021. That meeting tentatively, and it looks like it's going to happen, will happen in conjunction with the CPHA Western Pharmacists Education meeting. So that should be a very nice partnership. The other things that have been going on in training is we have a lot of webinars with our pilots, and so far, as I mentioned yesterday, they haven't complained, thanks guys, but they've been extremely, I guess, packed, I guess I could say, with information, with sharing, with coaching, with discussions of complex patient cases, with journal clubs. So a lot of work to make sure that we're all on the same page, that we're all up to date on evidence, and I think most importantly, sharing our processes for working with complex, challenging patients. We have one-on-one coaching that we provide to the teams each week that has accelerated their work and their partnerships. Excuse me. We have actually had meetings as well to partner pharmacies with medical groups and FQHCs, which has been very exciting and fruitful. And we have a process for quality improvement and data aggregation that has just launched as well. So a lot of pieces make this work all together. Now, obviously, this year has brought some different changes. I used to call it the new normal. It's now the normal, right? High school graduations are drive-throughs, and I have all the women in my house have hair that look like the one in the middle. I've done the one on the right many times where I get halfway to my destination, have to drive back home because I don't have a mask. I'm very tempted to take a piece of my car seat, put it in my mouth, but it doesn't really work that way. And look, Spock was well ahead of his time. I mean, we are at that stage where we live long and prosper is what we're going to say to everybody. But you know, with all those immense challenges are opportunities. I hope you all recognize that, and that's what this collaborative is all about. Is, you know, how do we adapt to the times? And some great examples I've seen is, you know, they talk about bonding with family. You know, you could actually buy a mask and bond with your pet. I don't know if that cat is excited about this, but that's one way to get closer to your pet. If you like karaoke, you miss going out and singing, you can do it at home. You can do it at home and not bother anybody. You were thinking about getting that nose job, but it was really expensive and took a long time. Well, you could wear this clip for 8-9 months and get the same results. And you know, people complain that, gosh, you know, I have small kids. It's really, you know, it's just so hard to do anything with them. Well, all hands on deck. You can help them clean your house with inventions like this. So the point is, you can think differently, right, in times where there are challenges. And boy, talk about a challenge that this pandemic has brought us. You know, not only you know, is it you know, we have issues with the economy and with all the lockdown, but the simple matter is that common chronic diseases left uncontrolled send patients to the hospital and kill them. And this is, and as I said before, last place in the world in healthcare quality. We were not doing well to begin with, and now we're paying the price doubly because it accelerates harm to our patients. So the work of this collaborative is more important than ever, and we need to find a way to make this work. So what you're going to hear today is a really exciting keynote session, some transformative leadership from national, state, and local perspectives. You're going to, as I said before, hear about the CalRight Meds collaborative journey, our progress, challenges, our successes. You know, hear about advancing community pharmacy-based CMM. I noticed that we have people from VA, from Kaiser. We're going to talk about how we can try to achieve that level of integrated care in a fragmented part of the healthcare system. We're going to learn a little bit about providing CMM for homeless patients. We have one of the nation's top leaders in homeless care speaking as a guest today. And then we have a breakout session, one session for our current pilots and one for our non-pilots. The non-pilots focusing on patient self-management and culturally diverse populations. And for the pilots, we'll be wrapping up a CMM webinar series that we've started a few months ago. So the question I'd like you all to run on is this, and that what I mean by that is, as you go through this day, keep this question in the back of your mind. What key insights will you bring back to your organization to advance optimization of medication therapy for your most vulnerable high-risk patients? All right, we're going to keep revisiting this theme over and over again today. We'd like you to be focused on that purpose and mission that we shared. Plenty of chances today to team up and interact with one another as we do breakouts throughout the day. We like to be actively listening, learning, thinking about how this applies to you, what you can do with this information. Stay grounded in proven methods, challenge ourselves. And at the end of the day, we're going to make requests, offers, and commitments and share them with the group. We definitely recognize from this article yesterday in CNN that you know, we're asking you for 8 hours, 6 hours today to be in the situation that you've been in for the last several months, which is in front of a computer, and it has effects on your breathing, on your thinking, on your posture, on your muscles, on your weight. Yes, all those things are true, and most of us are, you know, in this kind of setup where you know, we look great on screen, but if you look at the background, you know, in this case, they're not even wearing any pants, which I didn't think anyone sat in the screens not wearing any pants. So what I'm going to say is, if you have to get up and walk around, please do it, right? We want you to be healthy, we want you to be alert. Just turn off your video if you're not wearing any pants. We really would appreciate that. So Diane, I'm going to hand it off to you to do a little housekeeping before we introduce our first speaker. Oh, Diane, you're on mute, sorry.
So I did that on purposely, actually, to show you how it's so easy to be on mute and not realize it. So no, I actually forgot, which is a common thing with Zoom, it seems like. But yeah, so for the speakers, remember to place yourself off mute, or the host will do it for you. But my name is Diane Yoon. I'm the Associate Director of the Continuing Education Office, or the CPD Office, Continuing Professional Development. And I just wanted to go over with you a few quick things. I'm going to share my screen because I wanted to share a quick document that you should have received in your emails. Okay, let's see. Okay, so this one-page handout has important information. It has the agenda outline. We also sent you a full agenda in your email. If you didn't receive that, please either chat me or send an email to PharmCE, PHARMCE @usc.edu. We also have the Zoom meeting links. I know you received the one to log on to this meeting, but later today, when we do go into breakout sessions, which are different from breakout rooms, there is a separate Zoom meeting link for that. So we'll also chat that as well later today, just so that you have that, and it'll be easy for you to log on to the breakout session B, which will be later around 3:30 later this afternoon. If you experience any Zoom issues, any technical issues that come up, we do have a couple staff that will provide support, so you can email them. It's provided on the handout, but I'll say it again. It's you'll either email Mariel Romero at marielro@usc.edu or Victor Cow at victork@usc.edu. And lastly, I just wanted to mention for continuing education credit, we will be sending participants information to access the link so that you can fill out evaluations, as well as some of the topics will have post-test questions associated with them as well. So on Monday, you'll receive an email with more information on how to access those links so that you can get your CE credit. If you are here the whole day, you will be eligible to earn 6 hours. And if you're only able to participate in part of the day, then your attendance will show that. So you'll get links to the ones that correspond to your attendance. So feel free, if there are any logistical issues that come up with the program or anything related to CE, feel free to contact me by chat or email, like I said earlier, pharmce@usc.edu. Thank you.
Thank you, Diane. And so while you're pulling up the slide deck, I have the pleasure of introducing our first keynote speaker. Dennis Wagner has served the nation for a very illustrious 30 years as a federal servant in the EPA, in the Health Resources and Services Administration, and at CMS, going through progressive roles in staffing management and senior executive leadership. At CMS, he and his team supported healthcare providers who are using systematic quality improvement to make care better in literally tens of thousands of hospitals, nursing homes, clinical practices, and communities across this nation. His team of public and private quality improvers actively work to spread best practices of high performers. So the best practices become common practice is sort of his theme. Throughout his career, Dennis has worked to mobilize national action on diverse campaigns to improve hospital patient safety, increase healthcare access, increase organ donation and transplantation, make it socially unacceptable to be exposed to secondhand smoke, and so much more. I love something I learned about him when I was at HRSA. He attended a one-room country school in rural Montana for grades K through 8. And I believe he told me there were 12 people in his entire school. And there he learned that helping others to learn is one of the best ways you can learn yourself. Dennis is recognized by his peers as an enthusiastic, thoughtful, strategic person who believes in committing to and delivering in bold goals in work and life. And I can tell you, I've had the pleasure of working with Dennis. He is my mentor when it comes to a change agent in healthcare at a level I've never seen before. So really an honor to have the former Director of Quality Improvement and Innovation at CMS, Dennis Wagner.
All right, very good. Thank you so much, Dr. Chen, for that very kind introduction. I'm just going to quickly do a sound check, maybe directed to you, Stephen. Can you hear me?
Yes, very good.
All right, excellent. I'm going to go ahead and share my screen right now so that you can see the slides that I'm planning to share with you. I want to make sure that that comes through as well. So just to check on that, are you able to see my slides? All right,
Perfect,
very good.
yes,
So
yes.
we're gonna charge forward here. And I just want to say, first of all, that I'm very honored to be part of this activity, the California Right Meds Collaborative. I have really just the very greatest possible respect for Dr. Stephen Chen. I met Dr. Chen back in 2007. At the time, I was at the Health Resources and Services Administration. And we were looking for exceptional examples of organizations and clinics and private care organizations that were delivering exceptional clinical pharmacy services. And we were doing that not based on opinion, but based on data. We identified about 25 or 30 organizations across the country, and then decided to site visit about 20 of the best. And we wound up looking at Stephen's work and Stephen's team's work at USC with the pharmacies in the field there in your catchment area. And it was quite extraordinary. In fact, so extraordinary that we actually tapped Stephen to be one of our 2 collaborative co-chairs for a very large national Institute of Healthcare Improvement, IHI Breakthrough Collaborative, using the model that Stephen shared with you just a few moments ago. So I think you're very fortunate to have a leader of Stephen's caliber leading this particular effort. I'm going to say a little bit more about that as we go along, but I am very honored to be part of this group and have the opportunity to talk with 133 of you, is what I saw on the latest screen. So just want to deal with the formalities here and indicate I don't have anything financial or otherwise to disclose related to this presentation. Our 3 learning objectives for the session this morning are what you see on the screen here right now. And I'll just say that in 34 years of work at the U.S. Environmental Protection Agency, at the Health Resources and Services Administration, and for the last 10 years as a senior executive at the Centers for Medicare and Medicaid Services, what I've done during the course of my life, which has all been about mobilizing large-scale social change, trying to make things better on some of the things that you heard Stephen talk about in his introduction of me. And over the course of those 34 years, I have collected what, for me, are the most powerful leadership and management models that I've encountered in that time, working with, amazing people, people like Dr. Stephen Covey that wrote The 7 Habits of Highly Effective People, or Don Berwick, who was the founder of the Institute for Healthcare Improvement and was my boss, the administrator of CMS. I reported directly to him for 18 months when he was at CMS, and others. And what I've done is I've pulled out 4 of those leadership and management models that I'd like to share with you this morning that I think can accelerate your work with the California Right Meds Collaborative, with your work on clinical pharmacy services. And I would say even further, can make your life richer, right? These are things that are not only specific to career and work, but extend well beyond that. So these are the things that I'm gonna share with you this morning. How leadership is a self-accountability and what that means, how bold aims, I think, are key to generating results. And then this idea of leadership speech acts, that leadership occurs through language. So more on that when we get towards the end. As we begin, I think I would be remiss if I didn't acknowledge the extraordinary debt of gratitude that the nation owes to pharmacists, to nurses, to doctors and other caregivers, particularly during this time of the COVID pandemic. But even more broadly than that, these are challenging times. We've got political division in our country. A lot of the political division swirls around healthcare and the Affordable Care Act and the kinds of things that you all experience every day in your work. This difficult, technically difficult, complex business of linking payment to value, which is not an easy undertaking under any circumstances. And I think that the design that you all have created with the California Right Meds Collaborative is an exceptional one for doing that. And it is the right work at the right time. And it's not easy. And then in dealing with the populations that you're dealing with, we have systemic racism in this country, and that shows up with the highly vulnerable populations that need your care. The people in the California Medicaid program that are going to currently rely on, and I think will rely even more as you get deeper into the work of the California Right Meds Collaborative on your care to improve their chronic condition in a time when chronic conditions, as Stephen said earlier, are particularly hazardous for people who contract COVID. So thank you for the work that you're doing, and thank you for the way that you're doing that work. Now, you saw this graph. This is one of the many national efforts that I've had the opportunity to lead and be part of. This occurred back in 2003 through 2007 when Tommy Thompson was the Secretary of Health and Human Services. And we used the IHI collaborative methodology, the same methodology you're using here, to generate major national increases in organ donation. And you can see during the period of that collaborative that we went from an average of about 525 organ donors per month all the way up to around 675 organ donors per month. And we did it quickly. Now that work, you know, it's beautiful in retrospect. I'll just say it wasn't this beautiful when we were in the middle of it, right? And it wasn't this clear when we were in the middle of it either. And it wasn't a product of a single effort, a single initiative, or a single individual. It was the product of tens of thousands of leadership choices by individuals. And I'm going to share an example of what I mean about leadership choices by individuals. The lady that you see here had a phenomenal effect on the results that were on that prior screen. She was a single individual who made several choices over a period of 5 to 6 years that helped to produce the results that you saw on that slide. Her name is Susan McVeigh Dillon. She's a special education teacher, a mother, and a leader. So I want to tell you a little bit about her, all right? I met Susan in Dallas in 2004 when she told the story of her son Michael to teams of doctors and nurses and caregivers from 136 of the nation's largest trauma centers. And she began her story that day with how she got an urgent call at about 4 o'clock in the afternoon while she was processing her day's work at school. Her son Michael was at the local community hospital and she needed to come right away. It was a call that no mother wants to get. She showed up at the hospital. When she got there, she was met by a social worker. And she knew enough to know that when a social worker meets you at the door of the hospital, that things are not good. Her son Michael, after school that day, he was, I think, in the 9th grade, had fallen from the face of a rock cliff. He was climbing with friends after school, and he was badly injured, had a very serious head injury. And over the course of the next several days, she and her husband and her daughter gradually learned that Michael's injuries were so severe that although he had some minimal remaining brain function, he would never be able to eat again except through a feeding tube. He would never again be able to speak, that he would never regain consciousness again, and that he would require a ventilator to breathe. So she and the members of her remaining family of 3 made the toughest decision of their lives to remove life support and to allow her son and brother, her daughter's brother, to pass. And after consulting with the medical team about this decision, Susan asked that her son become an organ donor. And her thought was that some other mother in some hospital somewhere would be able to take her son home because Michael was an organ donor. And the medical team said, no, this couldn't happen for Michael in their hospital. That performing an organ donation retrieval after his heart stopped, this is called donation after circulatory death, when life support was removed, was not something that the hospital could do, that this would require meetings of the administration, meetings with the ethics committee, new rules to be promulgated by the hospital around their charter and more. And Susan made a leadership choice in that moment. She told him to get started and to figure it out. And despite several hours of hearing from the team that this wasn't possible, she and her family held the line on that decision. The hospital contacted the local organ procurement organization, Gift of Life in Philadelphia, and they agreed to work with Susan and with the hospital to do the first DCD donation they had ever done in Eastern Pennsylvania. The team at the hospital gradually swung into action. They convened the leadership. The CMO met with the ethics committee. They had all the things that they needed to do in order to process Michael's organ donation and the retrieval. And because of the leadership choice and persistence of Sue Dillon and her family, in the end, Michael became an organ donor. And his liver and his kidneys and his tissues saved or enhanced the lives of countless others. So when I say countless others, here's a picture. This is Santos on the left. He's a father of 2 young boys, and he got Michael's liver, and it saved his life. He would have died without that liver. You see Susan again, John Edwards, the guy from the organ procurement organization in Philadelphia, and then Dr. Avi Shaked, the transplant surgeon who both retrieved Michael's liver and also transplanted the liver into Santos and saved his life. So I met Susan about 6 years later when we were doing the work of this collaborative, and she came to Dallas and met with our 136 teams in this collaborative, some of the largest trauma centers in the nation. And at that time, only 2 organ procurement organizations, the one in Wisconsin and the one in Philadelphia, were doing this DCD donation. And Susan spoke to that group, and she said, these were her final words, and I'll never forget them. I have her video. It was like only maybe a 7-minute speech. At the end of it, she said, you know, I'm a special education teacher, and in my classroom, the words I won't or I can't are not allowed. And as leaders of the nation's largest trauma centers, when it comes to making it possible for other families to give the gift of life, I expect no less from each of you. And those teams went to work. And that year, we saw a 47% increase in DCD, more big increases in 2005. Today, all 58 of the organ procurement organizations do DCD, and they constitute about 21% of the nation's organ donors. And just to give you a perspective, in 2019, that was about 6,500 transplants that saved or enhanced someone's life as a result of DCD. And this was a product of choice. And it was a leadership choice. And the thing about leadership, I think people so often confuse leadership with a role or a position, and it's really a choice that a person makes. This is what is makes it a self-accountability. You choose to lead no matter what your role is. And then leaders align with emerging leadership voices to move on strategic efforts, like linking payment to value for clinical pharmacy services in Southern California. That's the nature of the opportunity that you're looking at here today. Now, I think of this as a model, right? As a leadership model, this business of choice. And here's why. This comes from, I learned it first from Stephen Covey, who begins almost all of his leadership and management books with this simple model of stimulus and response. Probably recognize this, right? This is sort of the foundation of the scientific method in social sciences. It's what CMS does with payment. Like, we put out a stimulus and we're seeking to lower costs and increase quality, right? To make value better. But as human beings, the reality is that the model looks more like this. Some stimulus is applied to us, and then we make a choice. We make a decision about how we're going to respond. And it doesn't have to be the knee-jerk response. In fact, a lot of the times the best decision is what I would call the road less traveled. That is the more challenging decision, the more difficult decision, the more complex decision, the decision that's harder to implement and requires me to learn and grow, like the decision to link your payment for pharmacy services to value, right? This is the heart of what it means to become human. Stephen Covey says that exercising choice is like going to the gym. It's like exercising the muscles of becoming human. That's what this is about. And leadership choice is at the heart of it. This model actually comes from a famous psychiatrist named Viktor Frankl, who wrote his seminal book was Man's Search for Meaning. Frankl was imprisoned in a Nazi concentration camp along with the rest of his family. He survived, the rest of his family. His wife did not. At the time he was in prison, he was the head of psychiatry at the major hospital in Vienna, Austria. His family didn't survive, but he did. And he attributes it to this business of choice. Choice of mindset, choice of how to behave, choice of how to act, choice of how to try to live with joy, even in a Nazi concentration camp. So first and foremost, and this is, in my view, the single most powerful model in the world, we can achieve our aims, the bold aims of this collaborative and other aims in life, I'm going to come back to that, by first choosing to make these things happen. Now, I want to just give you an opportunity to process this a little bit. It's not complicated, but I want you to kind of reflect on it and anchor yourself into it. And we're going to do a little experiment, at least for me it is. For Stephen, I guess it's not, and his team. We're going to do a 3-minute breakout. And all of you are going to go into breakout rooms right now. There are going to be 3 people in each room. And we want you to discuss your answers to one of these 3 questions. And then we want you to put it in the chat. And later on, we're going to come back and we're going to hear what some of you had to say. So you've got 3 minutes to do this. And I would like to say, go.
May I say before we go to breakout, so how it works is once you're in breakout, you can think of it as a physical room. This is how it was explained to me. When you go in that room, whatever you put in that chat, of course, it was a different room. So it doesn't follow you to the main room. So what I would propose is when you come back, you're going to put it in the chat here in the main room. Otherwise, we won't be able to see it. Thank you.
And really quick, for each group of 3, please make sure to assign a scribe to record or make sure that that person does chat for the group for the responses that are being answered.
So how about I just take 1 extra minute? So likewise, when you see the question right now that's showing, you won't have that in the other room. So I suggest that you take a picture of it or copy paste it. And then in terms of what Diane suggested, the scribe would then use the chat over there or some document to type it in. You're going to copy and cut and paste that when you come back to make it easier and faster. Thank you.
All right.
Okay, so we're gonna you're gonna see a screen come up and you just push join and you're gonna be zapped back out later when it's time. We have a few minutes in there.